All right, good morning, good afternoon, everyone. Welcome to today's webinar, Oral Health and its Link to Systemic, Economic, and Public Health. Part 1, The Mouth Really Is Part of the Body, an epidemiologic perspective on oral health and overall health. My name is Donnie Zemmel, and I'm the Training and Engagement Manager for the Region 5 Public Health Training Center. The RVPHTC is part of the National Public Health Learning Network, which is a consortium of 10 regional public health training centers and the country's most comprehensive resource for public health workforce development. We seek to strengthen the skills of the current and future public health workforce through learning tools, continuing education, and student development. We encourage you to check out our other training offerings on our catalog at rvphtc.org. This webinar is brought to you in partnership with the National Coalition of Dentists for Health Equity. This series will present the economic and health benefits of dental care on systemic health. And this first session will lay the foundation by discussing the associations between oral health and systemic health. Next slide, please. So just a couple of housekeeping items before we get started. All participants are in a listen-only mode. Please add your questions into the chat box. We will not be using the raise hand or Q&A functions in today's webinar. Depending on the question, we may type an answer back to you, or we may save it for the Q&A at the end, and we'll do our best to get to as many questions as we can. The slides were included in the reminder email sent out this morning, and they are also available for download from the Canvas course site, and I'll put that link in the chat momentarily. Today's webinar is being recorded, and we'll send out a notification once it's available. And lastly, there is no continuing education credit for today's webinar, but there is a certificate of completion available as long as you meet the attendance and evaluation requirements. And the evaluation opens at the end of the session. Next slide, please. So I'm now happy to introduce our moderator, David Mayware, who is the Managing Director of the National Coalition of Dentists for Health Equity. David is the former Executive Director for the Ohio Public Health Association and has over 50 years of experience in the nonprofit arena, managing complex local and statewide social service agencies and policy advocacy organizations. So without further ado, I'll hand it over to David to get things started for today.
Great. Good afternoon to most of you, and also thank you to Donnie Zemmel and the Region 5 Public Health Training Center. They've been a great partner to collaborate with for years now. So as she said, this is part 1 of a 2-part exploration of the connection between oral health and overall health. A little background on the National Coalition of Dentists for Health Equity first. Our purpose is to unite dentists who support evidence-based practices in the U.S. as a means to advance the goal of comprehensive health equity with a specific interest in oral health equity for all. Examples of such practices include community water fluoridation, the use of dental sealants, the inclusion of fully funded comprehensive oral health benefits in public programs such as Medicare and Medicaid, and the utilization of cost-effective workforce models such as dental therapists. Today, we're thrilled to hear from Dr. Scott Tomar. Dr. Tomar is a professor and associate dean for the Prevention and Public Sciences at the University of Illinois Chicago College of Dentistry, where he also serves as interim associate dean for research and interim head of the Department of Oral Biology. He is currently the president of the American Board of Dental Public Health. Dr. Tomar has written many journal articles and book chapters on oral health topics and was an associate editor of the recent NIH report on oral health in America, a long-awaited companion to the earlier report on oral health in America. And so I'd like to welcome Dr. Tomar and let him take the stage. Thank you.
Great. Thank you very much, David. Thank you, Donnie. And thank you all for being here this morning or this afternoon, depending where you are. First, just a couple disclosures. I have no conflicts of interest to declare on this. And also just that anything that I present today, even though I'm here on behalf of the Coalition of Dentists for Health Equity, my comments reflect only my own opinions, not those of the coalition or of my employer, the University of Illinois Chicago. So the learning objective for the series, that as Donnie mentioned, this will be a 2-part series. We'll be describing the connection between oral health and systemic health, recognize the economic benefits of dental care on the healthcare system in general, and discuss better health outcomes and longer lifespan when individuals have improved access to dental care. But for today, I really want to set the stage. First, talk a little bit about why oral disease itself is a public health problem, aside from its linkage with other health outcomes. In particular, we'll be talking about periodontitis and its role as a potential risk factor for other diseases. And then finally, I'll walk through some of the epidemiologic evidence for periodontitis as a cause of three of the major outcomes that have been associated with it, namely preterm birth, cardiovascular disease, and diabetes. So again, just to set the stage, many of you may already know this, but dental caries is, and for a long while has been, the most prevalent chronic disease in our population. These are just some relatively recent data from National Health and Nutrition Examination Survey, national data. And sort of the takeaway from this is that we really have not made tremendous strides in preventing this, theoretically preventable disease, that almost a quarter of American kids experience tooth decay before they start school. And by 8 years of age, more than half the young children in America still experience tooth decay. And this really continues throughout childhood. And again, we've, the takeaway from this, and this is the prevalence of dental caries or tooth decay in permanent teeth. We've seen a little decline in 9 to 11-year-olds, modest decline in 12 to 15-year-olds, probably associated with increased prevalence of sealants. But looking at it over time, again, kids are graduating high school with about 2/3 of U.S. kids and adolescents having experienced dental caries. So this very much still remains a public health problem, a very prevalent problem in the U.S. population. But again, I'm going to talk today mostly about periodontitis and its association with other health outcomes. For those who don't know, periodontitis is an inflammatory process. It involves inflammation of the gums and the supporting structures, the bone and other supporting structures for those teeth. And that inflammatory process is really what results in most of the destruction. There's certainly a bacterial component to the etiology of periodontitis, but it's really the host inflammatory response that leads to most of the bone and soft tissue destruction. It's a major cause of tooth loss in adults in the U.S. And as I'll be talking about today, that the inflammation associated with periodontitis has been implicated as a possible risk factor for a number of other non-communicable diseases and conditions. So this condition, periodontitis, based on the most recent data that we have, is a pretty prevalent condition in the U.S. population. So adults 45 to 64, overall, about 45% of Americans in that age group have periodontitis. About 10% have severe periodontitis, and about 35% or so have mild or moderate. And the prevalence of periodontitis even higher among those 65 and over. But overall, again, a fairly prevalent condition in the U.S. adult population. There's been a large body of literature that has come out, really in fairly recent years, no more than 20 years or so, that most of this stuff has been published. And I list here, and I'm sure I missed some. I've tried to identify the literature that's associated with periodontitis with some adverse health effects. And I've tried to group these, cardiovascular diseases. There's been, quite a bit of evidence that's come out on that, diabetes, and a variety of different pregnancy outcomes. And again, these three sort of broad headings are what I'm going to be focusing on today. But then there's been a large number of other conditions and diseases that have been associated. At least there's a small number of studies, including dementia, Alzheimer's, chronic kidney disease, various types of arthritis, particularly rheumatoid arthritis, a number of studies on various types of cancer and other health conditions. But again, today I'm really going to focus on sort of these first three categories, and in fact, really some specific outcomes in pregnancy outcomes, because there's a number of different pregnancy-related outcomes that have been investigated. But before I get into some of the meat of what we have out there in terms of data, I wanted to really kind of set the stage on sort of how we draw causal inference, and what epidemiology has to do with with this whole line of investigation. So ultimately, why we do epidemiologic investigations? Yeah, we describe the distribution and magnitude of a problem in the population, but ultimately, why epidemiology exists is to identify the causes of disease. Because ultimately, if we can identify a causal factor, we can do something about it. We can, we can prevent or remove that exposure, either clinically or on public health action. Because ultimately, our job is really to prevent disease, and so that one way, probably the best way to prevent disease is to try to understand what factors are associated with an increased risk for that disease. And there's a number of different guidelines out there. The one that I'll be talking about, it's really the one that's still being used to this day by the Surgeon General's reports. If you look at the footnote in this really goes back to 1964. And why I'm citing this, so 1964 was the landmark Surgeon General's report that concluded there was sufficient evidence, back in 1964 to conclude that smoking was a cause of cancer in human beings, particularly lung cancer. And so they laid out this what's called the Bradford-Hill criteria, which still really forms the most widely used basis today for judging causal association. So first one, temporal relationship. So we want to try to determine whether the exposure of the thing that we think might cause disease, we want to establish that it actually occurred in time before the onset of disease. The strength of association, so generally the stronger the association between some exposure and some disease outcome, the more likely it is to actually be a causal relationship. And there's a number of different measures, things like odds ratios and rate ratios, and I'll be talking about a couple of those at least briefly. Dose response relationships. So yeah, one of the things we try to see is whether people that have more exposure, are more likely to have the outcome than those that have less exposure. So, those who smoke more cigarettes have a higher risk for lung cancer than those who smoke fewer cigarettes, and so on. Replication of the findings. As I tell my students, we almost never make clinical or public health decisions based on one single study. We want to see that study repeated in using a variety of study designs and a variety of types of populations. We really want to see more than one study reach a similar conclusion. Biologic plausibility, again, it's certainly a causal relationship. Is bolstered if we have some reasonable biologic explanation for this. One caveat is that often people will come up with post hoc explanations of things that they saw, but again, all things considered, if we have some reasonable biologic model for why we would expect there to be a causal relationship, it helps. Consideration of all alternative explanations. So this gets at whether these studies have ruled out things like major confounding, the presence of other explanations for the association that we observed. We want to see if we can somehow reduce the exposure. So again, I'll use the smoking example. If people quit smoking, is there a reduced risk of lung cancer compared to those who continue to smoke, and so on? And is it consistent with other knowledge? So is this the causal relationship that or I should say the association that we see? Is this supported by other supporting evidence? Is this the general trends in the exposure in the population and the general trends of disease? Does it make sense that if we're seeing more periodontitis, or are we seeing more of whatever the outcome is that we think might be associated with it. And so I'd say Surgeon General's reports, certainly in the past 10 years or so, have adopted this 4-level classification on the strength of causal inference. Because again, at the end of the day, what we really want to do is take the full body of evidence that we have and make some statement on the strength of evidence supporting a causal inference. And actually, this is really the classification now used by the Surgeon General's office. It's used by the International Association for Research on Cancer, International Agency for Research on Cancer. And so again, it's probably one of the more widely used classifications. So, the top level evidence is sufficient to infer a causal relationship. So generally we'd want to see that, almost all, all or almost all of those criteria that I just showed, were generally met in the body of evidence, suggestive but not sufficient to infer a causal relationship. So yeah, maybe we have pretty good evidence in some areas. Maybe we still don't yet have studies that have ruled out alternative explanations and so on. The evidence is inadequate to infer the presence or absence of a causal relationship, but this is often a case where maybe we only have 1 or 2 studies and we don't yet have good biologic explanations and so on. And evidence is suggestive of no causal relationship. So this is really often a somewhat rare condition, but one where we have a fairly robust body of literature. A lot of studies have been done, and they're all pretty consistent in showing no relationship. So again, you tend to not see a whole lot in that last category. And and based on the strength and evidence, I should say, based on the type of studies that contribute to our body of literature, really contributes to the strength of evidence we have. And again, there's lots of examples of this kind of pyramid of hierarchy of evidence. We start at the bottom, with sort of expert opinion. You put 5 experts in a room, and you probably get 5 opinions. But often when we don't really have good data, we start with what do the experts think? What's been observed by an astute clinician in their practice. Then that leads to to kind of move up to looking at has there been at least a few of these cases reported in the literature? Then moving on to various types of observational studies like case control or cohort studies, up to actually the randomized controlled trials, which is probably considered the strongest of the what we call unfiltered information. Again, single studies, they contribute some degree of evidence, but really what we want to try to get to is things at the top of the pyramid, what we call filtered information. So things like systematic reviews, where somebody has really scoured the literature. They've told us how they've scoured the literature to find every study that tries to answer that research question, and what's the preponderance of evidence support, and then the extent of that meta-analysis. They take the data from those studies and try to combine them in a statistical way to have some sort of bottom line estimate of what really is the association between this exposure and this outcome based on all the available studies in the world that we could find. And so again, as I walk through some of the conditions that we'll be looking at, I'm going to kind of walk you through sort of those steps of how we got to where we are today on the body of evidence supporting some of these. And again, as I said before, again, our primary goal in epidemiology is to try to identify causes of disease. And this is sort of the typical sequence, and it sort of follows that pyramid of evidence I just showed you. We start at the bottom, clinical observations. Maybe an astute dentist or physician notices something. They see it a few times in a few patients, so they lead to a case control study. It's like, do the people that have this outcome compared to the ones that don't have this outcome, do they differ in their exposure to what we think might be causing disease? And then that leads to cohort studies, and then move up to randomized controlled trials. And finally, have there been enough studies done that we can actually do a systematic review? Because again, ultimately, what we try to do is take these clinical observations and see if they're real, and if they are, what can we do as public healthers to try to prevent this condition or reduce this condition in the population. So, I'm going to start with periodontitis as a potential cause for preterm birth. And again, just to sort of, to frame this in terms of its public health importance, preterm birth remains an incredibly high incidence occurrence. It's one of the primary causes of neonatal mortality worldwide. With more than a million deaths worldwide caused by this, and about 15 million preterm births. And it's been estimated, relatively recent data, about 12% of U.S. births, or I should say, births in the United States, are preterm delivery, and that varies by in various racial and ethnic groups and socioeconomic status. But still, it's overall it's a fairly prevalent condition. One of the challenges we have, there's been a lot of studies that have identified a large number of probable risk factors. But at least based on the best available evidence, about 2/3 of preterm births do not have they have not yet identified the risk factors that were involved. So we still have a lot to learn about what really causes preterm births. In terms of the dental connection to preterm birth, the earliest reference I could find really goes back to the 1930s. There was a kind of somewhat of a case report from this physician, Galloway. Actually, he was an OBGYN. And he claimed that chronic periapical infection was a cause of pregnancy complications and miscarriage. And again, at that time, he really had almost no data to back up that statement. But regardless, he based on he asked all of his pregnant patients to go get a full series of x-rays from their dentist. Based on those x-rays alone, he sent 36 women to have teeth extracted. And claimed that of those that had extracted, none of them had a miscarriage. Not the strongest and perhaps not the most ethical study design, but that's where things started. And then the literature was quiet for decades. The first known epidemiologic study that I could find that investigated this potential connection between a dental infectious process or inflammatory process and preterm birth really was just came out in I said just, I mean, it wasn't that long ago in history, but what was first published in 1996 by the late Steve Offenbacher's group at UNC, and I'll be talking about that study a little bit more. So in this particular study, it was a case control study. So what they did was identified a number of women that had a preterm low birth weight. So they had 93 women that met their case definition in that study, and then that they identified women that were seen at those same hospitals that had a normal birth weight infant. And in this particular study, their case was both preterm and low birth weight. And so they had a control group of babies that had a normal full-term delivery and normal birth weight. So they had 31 controls, and then they went back after they delivered. They examined the mothers for their periodontal health, and actually found that the women who had a preterm low birth weight delivery were 5.9 times more likely than pregnant women without periodontitis to, or should I say they were 5.9 times more likely to periodontitis than were the controls, those that had a normal term delivery with normal birth weight. So again, thinking back to our causal criteria, one of the big limitations with a case control study with that kind of design, we don't know whether that periodontitis existed before pregnancy or started during pregnancy or what. So again, one of our first criteria for causation is temporal sequence. We want to know, that the periodontitis really preceded the onset of any birth complications. So then that led to a number of cohort studies, and then this was again just one example of a cohort study. So they took a group of pregnant women earlier in their pregnancy. Some had periodontitis, some didn't. They followed them, through the course of their pregnancy to see whether or not they carried full term or had a preterm delivery. And at least in this particular cohort study, you can see they had 338 women who had periodontitis early in their pregnancy, 958 who didn't have periodontitis. And among those who had periodontitis, they had a larger proportion had preterm delivery compared to those without periodontitis. So relative risk of 1.77 means that those with periodontitis were 1.77 times more likely to have a preterm birth. So again, this is again just one example. But again, we don't want to make public health or clinical decisions based on just one study. So there actually have been a couple systematic reviews that have tried to scour the literature for all observational studies, all case control or cohort studies that have looked at this outcome associated with periodontitis. And so in this particular study, they limited it to observational studies, 15 observational studies that were included, including case control and prospective cohort studies. The bottom line from this, and again, this particular chart, it's called a forest plot, sort of plots out the findings from each of the individual studies, and at the bottom they come up with an overall statistical average. You can think of it as a way of summarizing the findings. So, for me, the first takeaway is all 15 of these studies that were included in this meta-analysis. All of them had a positive association between periodontitis and preterm delivery. So they all, 15 studies consistently found that the presence of periodontitis was associated with a greater likelihood of having preterm delivery. And then the bottom line was, a summary odds ratio 1.57. So again, you can interpret that overall, averaging together these 15 observational studies, on average, about a 50% increase in the odds of having preterm delivery compared with women that did not have periodontitis. But again, these are observational studies, which they carry their own limitations. Particularly potential for confounding maybe being the real explanation for the observed association. And one of the things I mentioned here that these 15 studies included about 38 potential confounders, but no one study controlled for all of them. So then we try to move on to the next higher level of evidence that we have, randomized controlled trials. And so the real strength of doing randomized controlled trials, we can control for some major sources of bias. By randomizing, we potentially can control for a lot of unmeasured confounding. By blinding or what's also known as masking, we can try to reduce any bias, on the part of the examiner or the bias statistician. And it includes a placebo. And again, in an ideal randomized controlled trial, the people don't know whether they're getting, the intervention or the placebo. So, again, considered sort of the gold standard in terms of, individual study design, providing evidence towards making a causal conclusion. And again, I just put this out there as another example. This was also by Steve Offenbacher's group. They did a randomized controlled trial of 806 pregnant women with periodontitis, and then they randomly assigned them to either getting the periodontal treatment early in their pregnancy or waiting until after they gave birth. So again, they were randomized to controlling, either controlling or not controlling that periodontitis during pregnancy, and then looked at the outcomes. And again, the bottom line in this one, really not much difference in outcome, in the intervention group compared to the control group. So in the intervention group, about 13% of the women had a preterm delivery, 11.5% in the control group, but not at all statistically significant. So at least in that study, no significant benefit of the scaling and root planing earlier in the pregnancy. But again, we don't want to make decisions based on a single study. So, then we say, all right, is there a systematic review that's looked at, with multiple randomized controlled trials? And so, I found at least 15 published randomized controlled trials that looked at periodontal intervention among pregnant women with periodontitis. What's interesting is that there's as many published systematic reviews as there are original studies. So at least 15 published clinical trials, but also at least 15 published systematic reviews that I found. Of those, even systematic reviews vary in their quality. Only 2 of those that were rated as high, at least in this one systematic review of systematic reviews that I found. And so actually, I'm going to talk about one of those. The Cochrane library, for those that don't know, among systematic reviews, it's by far the gold standard of systematic reviews. It's still considered probably the highest quality, best done systematic reviews for answering a clinical question. And so they actually did have a review. It came out about 5 years ago. Does treating periodontitis during pregnancy prevent preterm birth? And in that study, in that review, and again, I put the reference there. It's the full review is probably about 60 pages, but this is one of the main forest plots from that review. And again, I know it's difficult to actually read the small print. This just sort of shows the individual studies, and they look at this in 3 different outcomes. And one is this top part of that. They look at those that use the definition of birth before 37 weeks, and then there was a few studies that looked at birth before 35 weeks, and then a couple studies that looked at birth before 32 weeks of pregnancy. And sort of the takeaway message from all this is that, really, regardless of the outcome of the outcome measure, really no significant treatment effect from the periodontal treatments that were used in these studies in terms of reduced risk for preterm delivery, regardless of which definition they used. For all these the summary risk ratios were not statistically significant. And so their conclusion in that review was it's not clear if periodontal treatment during pregnancy has an impact on preterm birth. There was some low quality evidence that it might reduce low birth weight, but that was based on just a few studies. So they said their confidence in that effect estimate is limited. Insufficient evidence to determine which periodontal treatment is better to prevent adverse obstetric outcomes, and future research should aim to report periodontal outcomes along with obstetric outcomes. And the reason that they mentioned that last recommendation was because on many of these studies, they provided a periodontal treatment, in most cases scaling and root planing, but in a number of studies they didn't really assess just how effective that was in reducing periodontal inflammation. So they did a treatment, but again, if our hypothesis is that it's the periodontal inflammation that's really the risk factor for the adverse pregnancy outcome, well, we want to know whether that treatment really reduced periodontal inflammation, and in some of the studies that didn't really report that very well. So again, the second big group of diseases that have been looked at, cardiovascular diseases. And again, this is a pretty broad range of diseases that fall under the category of cardiovascular diseases. It includes things like coronary heart disease, peripheral artery disease, stroke, and other cerebrovascular diseases. But if you take these, as a collection, overwhelmingly the world's largest killer. It kills, about 18 million people per year. There's been a number of other, risk factors that have already been pretty well established, like smoking and sodium intake and obesity and so on. But there's been a large number of studies that have implicated inflammation as a potential etiologic factor for a number of cardiovascular diseases, and it's thought that that infections that accelerate vascular inflammation and promote thrombosis might be an etiologic pathway by which something like periodontitis could potentially increase the risk for cardiovascular disease. And as I showed early on, I mean, these are, at least in the US and most other countries, is a pretty common, if not the most common, chronic infection in the population, with somewhere about 40% of US adults having periodontitis. Again, I'm not going to walk through this whole thing, but there's been a number of publications that hypothesized the biologic mechanism by which periodontal infection and inflammation could lead to systemic inflammation and contribute to a number of different pathways for a number of different types of cardiovascular disease. Whether it contributes to systemic inflammation that then can contribute to things like cerebral vascular accidents, myocardial infarctions, and so on, or whether the pathogens can lead to a more localized inflammation in arteries and lead to things like peripheral arterial disease. But again, it really all starts with the idea that inflammatory process associated with periodontitis could be contributing to an inflammatory mechanism in these cardiovascular diseases. And there's been, similar to what I showed for pregnancy outcomes, there's been a number of cohort studies that have been done looking at whether periodontitis predicted incident cardiovascular diseases. So at least in this particular systematic review, they identified 32 longitudinal cohort studies with 4.8 million people among those studies. A number of them, had some individual studies had some risk for bias. But again, sort of the takeaway from this is that, based on the studies that they identified, consistently seemed like those subjects with periodontitis had a higher risk of having a cardiovascular disease over the follow-up period compared to those that did not have periodontitis. And these were overall fairly long follow-up period, a median follow-up of about 14 years. And then a number of these, in that review, it also said that there's also evidence among these on a dose-response relationship. So in other words, those who had more severe periodontitis seem to be at higher risk for incident cardiovascular disease. So that leads to the question of, well, if we treat periodontitis, can we prevent cardiovascular disease? And again, there was a fairly recent Cochrane review that was done on this. They included randomized controlled trials that compared an active periodontal treatment to no treatment or a different treatment, and included studies with a diagnosis of moderate to severe periodontitis. Most of the effect on this, all the interventions were non-surgical. Almost all of them included subgingival scaling and root planing. A few of them also included antibiotics or other host modulation. And then the outcomes that they looked at was either all-cause or cardiovascular disease-specific deaths, or other cardiovascular events like angina or myocardial infarction or stroke. So the takeaway from all this, and again, the Cochrane review is by far the highest quality, but also the most stringent type of systematic review. And at the end of the day, only 2 randomized controlled trials met their inclusion criteria. Just one, which was primary prevention. So in other words, the testing whether treatment of periodontitis prevented an incidence of any cardiovascular disease, and one was secondary. So it was among a population that already had experienced the cardiovascular disease, and looking at whether it prevented a more severe outcome like death from cardiovascular disease. And then the main conclusions was, there was very low certainty evidence, and it was inconclusive about the effects of scaling and root planing plus antibiotics compared to supragingival scaling for primary prevention. No reliable evidence regarding secondary prevention of cardiovascular diseases in people that had already been diagnosed with a cardiovascular disease and with periodontitis. And of course, they really recommended that we need further trials. So again, the jury's still somewhat out. And then sort of the third sort of broad area looked at diabetes. For those that aren't aware, chronic metabolic disease caused by the body's failure to either produce insulin or use it effectively. Highly prevalent in the U.S. About 11% of the U.S. population, or about 37 million people, have diabetes, and many more have prediabetes, and lots of severe adverse health effects associated with diabetes, especially poorly controlled diabetes, and we spend a lot of money treating it. So there's there's been a lot of discussion in the literature for quite a while on diabetes and periodontitis having what's known as a bidirectional relationship, because diabetes has long been considered a risk factor for onset of periodontitis. But then I'd say, again, we've got an emerging body of literature showing that periodontitis can be a risk factor for both onset of type 2 diabetes as well as poor glycemic control and other adverse health effects among those who've already been diagnosed with diabetes. And again, it's really thought again that this is working mostly through a mechanism related to inflammation. So again, fairly consistent body of literature in this particular systematic review on diabetes being a risk factor for incident periodontitis. And we sort of suspected this for a while. But then there's actually a number of studies, at least 10 cohort studies that were identified for this particular thing that identified that these studies, again, fairly consistently, now, although, modest effect, but relatively consistently found that those who had periodontitis had a slightly elevated risk for developing incident diabetes. And then, several different systematic reviews that looked at whether the presence of periodontitis complicated glycemic control, and at least one systematic review concluded that it was fairly consistent that it did, and another systematic review concluded that those who, among people with diabetes, those with periodontitis had significantly higher risks for a number of adverse outcomes, including retinopathy, neuropathy, and so on. So again, the preponderance of data from observational studies, does support this sort of bidirectional association between periodontitis and diabetes. But then, the question is, well, does treating periodontitis improve glycemic control? And again, I'll lean on the Cochrane reviews for this. They found 35 randomized controlled trials that tested this, this hypothesis. 30 of those studies were included in their meta-analysis. Overwhelmingly, they were patients with type 2 diabetes, and they were followed for 3 to 12 months after periodontal treatment. And what they found in this review is that after 3 to 4 months, absolute reduction of A1C of about 0.43%. Reduction after 6 months, after 12 months. Fewer studies contributed to each one of these, but And this review just came out a few months ago and actually reversed the conclusions from their review 5 years ago. And in bold, I have the conclusion from this most recent systematic review from Cochrane Group. We now have moderate certainty evidence that periodontal treatment using subgingival instrumentation improves glycemic control in people with both periodontitis and diabetes by a clinically significant amount when compared to no treatment or usual use. And further, they said further trials evaluating periodontal treatment versus no treatment are unlikely to change the overall conclusion reached in this review. Which, so this is actually, to me, somewhat of a landmark finding. It's really among the major conditions we've looked at, the first one that's really found, really at all levels of evidence, good observational studies individually, systematic reviews of those, and now systematic review of randomized clinical trials, fairly consistently are showing that this is perhaps more than just an association. That reducing the periodontal inflammation did improve glycemic control to a degree that was both statistically and clinically significant. And so, by summary, I know I've thrown a lot of data at you this morning or this afternoon, but I'd say, so far we've got fairly consistent evidence from cohort studies that periodontitis predicted preterm birth, cardiovascular disease, and type 2 diabetes. The biologic mechanisms, and there's, again, I didn't even get into that body of literature, but the biologic mechanisms likely related to systemic inflammation, related to the localized inflammation that characterizes periodontitis. We now have moderate certainty that periodontal treatment improves glycemic control. And again, I would say that where this is significant, not only in terms of its impact on the control of glycemic control in people with diabetes, but again, to me, this really suggests that reducing periodontal inflammation can have broad systemic benefits. So while that's specific to diabetes, I think potentially this has broader implications in terms of the impact of periodontal treatment and periodontal health. And so again, my takeaway, again, this is my interpretation, that the insufficient evidence that we have so far on periodontal treatment as far as reducing the risk for cardiovascular disease or preterm birth does not mean that periodontitis is not causal. It just means we don't yet have enough high quality studies, or we need to rethink, how we design those studies. But the absence of evidence is not equivalent to the evidence of absence of a causal relationship. And so my bottom line conclusion on this body of literature where we are so far today, my takeaway is that the evidence is now sufficient to infer a causal relationship between periodontitis and glycemic control in persons with type 2 diabetes. I think that we've met all of the causal criteria, a large number of very consistent observational studies, and now a preponderance of evidence from a fairly large number of randomized clinical trials. The evidence is suggestive but not yet sufficient to infer a causal relationship between periodontitis and preterm birth, and my conclusion is the evidence is also suggestive but not sufficient to infer a causal relationship between periodontitis and cardiovascular disease. And so that's sort of where we are today. And again, I would urge you all to come back for part 2, because I really want to take at least the evidence that we have so far and really start putting this into a broader picture. What does this mean for the impact on overall healthcare system, on healthcare expenditures, on how we cover dental care? I think there's a lot of implications related to this. I think next time we can maybe talk about, well, at least I plan to talk about some of the studies that have specifically looked at some of these population outcomes, and then, we'll then talk about where we go from here. What does this mean in terms of clinical practice, clinical guidelines, and public health action, and so on. So I would urge you all to come back on January 11th. We'll be opening registration soon. And with that, I will put the contact information for the Region 5 Public Health Training Center. And with that, I thank you very much for your attention, and I think we have a few minutes for questions.
We do. Thank you so much, Dr. Tomar. That, as you said, quite a bit of information in a fairly short period of time. And I'm glad you're with us today, because a couple of the questions really ask for extrapolation. From Bob Russell, he wonders, while diabetic improvements are demonstrated with current dental interventions, what about the other chronic conditions mentioned?
Well, as I said, where we are so far on the other chronic conditions, we have fairly consistent observational studies. Some case control studies, cohort studies are, based on the high quality systematic reviews that are out there. The studies are fairly consistent. Now, that doesn't mean that they're perfect, because, again, one of the limitations with, even well done observational studies, we can't rule out the possibility of confounding or other potential explanations. With all these complex chronic diseases, there's multiple pathways. And so, to some extent, maybe it's not surprising that we would expect, something like scaling and root planing. Do we really expect this to prevent heart attacks? On the other hand, we really have a fairly, in the Cochrane review for cardiovascular diseases, we only have 2 studies that met their inclusion criteria. So, I would say that the evidence is probably going to continue to gather, similar to what we saw with diabetes. I think there's a number of ongoing studies, and we will probably see the data out there. But again, my extrapolation is, based on what we've already seen for diabetes, there is good reason to expect that the local inflammation from periodontitis, can lead to systemic inflammation, which can be a causal pathway for a number of other diseases. And we just need further data on some of these others.
Great, thanks very much.
Sure.
Where can we expect some research to come from, especially in the when the question is asked about impacts on preterm birth?
Where can we expect the
right where can we look for new research that is being done?
Well, again, I think that there's actually a fairly large number of studies that have been coming out in just recent years. Cochrane, which I know is, it's only one type of systematic review, and they tend to only review treatment studies. They don't do observational studies typically. But they've already said that for a number of these major research questions, they plan to revisit them on a regular, periodic schedule. So, I showed the one for glycemic control and diabetes. Cochrane Review had already announced a number of years ago they are going to redo their systematic reviews at least every 5 years. So I think you're going to continue to see, as the literature grows, you're going to continue to see it being summarized in high quality systematic reviews. Again, it's hard for anybody to keep up with individual studies, but what I always tell my students, when trying to make clinical decisions, start with the best available evidence. Is there a good quality systematic review you can start with? And so that's, again, my advice. Don't try to digest the world. Try to look for high quality either systematic reviews or summarized reviews. There's a number of different journals that try to distill, really try to make evidence-based findings easily digestible for practitioners. There's Journal of Evidence-Based Dental Practice, Evidence-Based Dentistry. Both of them exist exactly for that. But I'd say, just stay tuned for reviews that'll be coming out.
Great, thank you very much. I have one last question from Bob Russell, and it is, Is the problem with the lack of evidence for improving associated chronic diseases a lack of effective current dental therapeutic interventions?
Great question, and that may be one of it, and one part of it. And in fact, it's even touched on in a number of the systematic reviews. For example, they randomized somebody to get scaling and root planing, or to get, in fact, a lot of them they just did, scaling above the gums, what they call super gingival. Well, if they don't measure whether that subgingival scaling and root planing really reduced periodontal inflammation, yeah, they did a treatment, but yeah, we don't really know whether it truly reduced, inflammation, or reduced it sufficient, to have reduced to remove that as an etiologic factor. It's kind of amazing, with as far as we've come in oral health care, we're still using similar treatment approach to what's been used 50 years ago. We use, scalers and curettes to go down there and, pick away at stuff. But yeah, maybe when our diagnosis and treatment of periodontitis becomes, a little more biologically advanced,
Right.
or perhaps.
Well, thank you. I don't see any additional questions down in the chat. I think that people are pleased with the presentation and looking forward to the next presentation in January. So again, thank you, Dr. Tomar, for the presentation. Thank you to Donnie Zemmel and to Riley to help us move through this. Really appreciate it. And for all the technical support that you provided today.
Yeah, I'll just chime in really quickly here before we sign off for the day. I've put a link in the chat. We'd really appreciate for all of you to give us feedback so that we can continue to improve for future trainings. And that also is a requirement in order to receive your certificate of completion. And if there are any follow-up questions, feel free to reach out to us via email. And I'll put our email in the chat as well at rvphdc@umich.edu. And I think with that, we'll go ahead and wrap up a couple minutes early. Thank you all, everyone, for being here. Thank you, Dr. Tomar and David, for being with us today, and hope everyone has a nice rest of the day.
Great, thanks.
Thank you all.